Good afternoon, everybody. My name is Eric Saviano. I am the Program Associate with Nebraska Appleseed and the statewide lead for Enroll Nebraska. Welcome to our Enroll Nebraska webinar on healthcare current events. We are going to cover some of the hot topics that are happening with the federal branch of government, and we are going to be taking lots of questions at the end. So just a few things before we get started. This is in listen-only mode for everybody on the call, on the webinar. If you have questions, we will be monitoring the chat box in the bottom right-hand corner of your screen. And we will do our best to answer those questions as they come in. There are sure to be lots of questions, and we're excited to answer those. So we may have to push them till a designated time at the end of the webinar to get through it within our allotted time frame. So this is one of our webinars in a continuing series. We try to do these about once a month and support enrollment assisters and community organizations about what's happening with healthcare in Nebraska and around the country. And we have a few coming up that I want to draw our attention to right away. We're likely going to have the Medicaid managed care providers available to answer questions and to present with an in-person presentation that's coming up in possibly April. We don't have that settled down yet, but I will be sending it out over the email system. And if you've registered for this webinar, then you're automatically on our email system, so congratulations on that. We are also going to do our follow-up to this. Likely a lot of this information will be kind of thrown out the window as things change and move in the federal government and as things try to pass in Congress or get changed. So we are going to do our best to keep you all updated with important information as things move forward. So there's me. I'm the host of this webinar. And that's my email address at Nebraska Appleseed. Enroll Nebraska is a coalition led by Nebraska Appleseed with lots of different partners that we'll talk about in just a few minutes. We are going to, like I said, discuss Enroll Nebraska. Love to give you just a brief overview of what we do and how we do it. Also, we'll talk about some of these main topics that are happening at the federal level, AHCA, and also known as ACA as around our office. Also the insurance market stabilization proposed rules, and questions and answers. Everybody, the webinar materials that you will likely need to refer to as we go through this webinar presentation are going to be found at enrollnebraska.org/EEG. That's where we host all of these. We call it our education and engagement group. And it is basically our effort to get word out into the community to support people getting enrolled in Affordable Care Act coverage, as well as Medicaid and CHIP in our state, in Nebraska. So please visit that website, download these webinar slides. If there are technical difficulties, we've learned that reloading can support resetting the system, or CS. Also, you can just wait. We're hopefully have our internet system figured out on our side. So sorry about the technical difficulty. If they happen, put them in the chat box if you experience them, and we'll see if other people have experienced them as well. So I'm going to go into what Enroll Nebraska is very quickly. Enroll Nebraska is a statewide network of community organizations, enrollment assisters, healthcare providers, and advocacy groups. We have been around since the beginning of the Affordable Care Act and have worked to engage all of these stakeholders as well as the community in expanding the reach of the Affordable Care Act, because we believe it is the game-changing legislation, the biggest change in healthcare since, and it is proven to be since Medicaid and Medicare were first introduced. So our goal was to support Nebraskans who need insurance and get the word out as quickly as we can. Check us out on social media as well. So for this webinar particularly, I wanted to draw out Enroll Nebraska's role as the statewide coalition. We are part of a nonprofit, and that means that we have some limitations and boundaries, so let's dive into them quickly. For this particularly, I think it's important to note that we are not psychic. We do not know what will happen next, so some questions that you will likely have that come to your mind are the same ones that come into our mind. How possible are some of these changes? How is it going to move forward, and how quickly? We don't really know exactly what will happen, except for what the legislators and folks in charge have told us. So we do our best to report that to you and report it accurately. The second thing that we are not are major advocates. We have boundaries against lobbying, which include asking folks to perform next steps and encouraging them to next steps such as addressing legislators at state and federal levels. So we do our best to avoid that as best we can. Some things that we are educators and are doing our best to get out in the community. Like our group says, we're education and engagement, trying to keep you up to date on what's happening and offer resources to continue the push for enrollment. Lots of you are community organizations, but some of you are also enrollment assisters who are helping people get enrolled in person as we speak, likely. So it's something for you to know. We are a resource for you. We can be reached after this webinar as well, and we hope that you can take us up on that. Finally, we are connectors. We believe in the power of referrals. I'm going to post some information in the chat box right now with information that you can take and get connected with other folks like us, but who may not have similar restrictions. My copy paste, oh, there it goes. It should, oh, no, not yet. They're tricking me with all of these new buttons. These are some places for you to get connected. EnsureTheGoodLife.com is Nebraska's advocacy effort. Families USA is a national effort, and also Community Catalyst is a national effort. All of these are ways that you as individuals, or possibly through your role in your nonprofit, can get engaged with these topics. So with that, feel free to ask any questions as they come up. You'll also notice on the enrollnebraska.org/EEG webpage, there are several different downloadable resources for you to use during this call. I want to download those if you can right now, and they will be useful as Molly McCleary, our staff attorney at Nebraska Appleseed, takes over and talks a little bit about healthcare current events. There's the web address for those downloads right there. So with that, I'll hand it over to Molly.
Hi, everybody. As Eric mentioned, my name is Molly McCleary. I'm the staff attorney here at Nebraska Appleseed in the Healthcare Access Program, and I'm going to be talking about what's going on in Congress right now with the ACA repeal. I'm sure you've all heard there's a lot happening and things seem to be moving really quickly. So we wanted to just break it down as easily as we can to help folks understand what's happening, and then let you ask questions if you have them. So let's start with the procedure kind of stuff. I don't know about you all, but I never learned about this budget reconciliation process ever in civics class or high school or college or anything. So it's a little bit of a different, kind of more complicated process. So that's what we'll walk through here in just a second. This is the process that Congress, in particular the House of Representatives, has started to use to repeal and replace the Affordable Care Act. Budget reconciliation can be used to take out pieces of the ACA and sort of tweak pieces of the ACA with only 50 votes. Normally, you need 60 votes to pass legislation, but under the budget reconciliation rules, you can't have a filibuster in the Senate, and you need 60 votes to overcome a filibuster, and so that's kind of where this comes in. Bottom line, representatives, in using the reconciliation process, can push through legislation with fewer supporters than they would need if they were doing it through traditional processes. So that's why we're using reconciliation. The thing about reconciliation is it can only be used to impact things that have budget impacts. So it can only be used to address parts of the ACA. Not all of the ACA impacts the budget. When I mention the budget, what I'm referring to is really taxes and spending at the federal level. So if you think about a lot of what the Affordable Care Act does, like pre-existing conditions protections or letting young adults stay on their parents' plan until they're 26, that stuff doesn't really have an impact on the national budget or on taxes and spending. So you can't use budget reconciliation to get rid of or modify those pieces. So there's only so much that can be done through this process, and that is why the Trump administration and leaders in Congress have noted that this is probably the first step of a three-step process. The first step being this American Health Care Act that was introduced last week, the second being some regulatory changes, and the third being additional pieces of legislation done through the normal process where you can do more than just budget things. So this is the normal budget process. So if we go back to like Schoolhouse Rock, this is how bills become laws. The president submits a budget request to Congress. The House and Senate pass budget resolutions. The Appropriation Committee in both houses mark up the bills. That means they have a hearing on it. They may make changes, make amendments, things like that. They take a vote. And then they reconcile the differences between those two bills, and then the president signs it and it becomes law. That's kind of the normal budget process. This is different than the process we're using now. The process we're using now is where there's a resolution with reconciliation instructions. The committees that have jurisdiction over the Affordable Care Act, so in the House, that's Energy and Commerce and Ways and Means, they come up with legislation that responds to those instructions. Then they mark up or have a hearing on and modify the bill. It goes to the Budget Committee of the House. The whole House votes. Then it goes to the Senate. The Senate can change it if they want to. Then they vote. Then they conference the bills together or look at the differences between the bills and kind of put it in one bill, and then it's signed or vetoed by the president. So it's a little bit different of a process. The reason why two of the squares on the arrow are in red are those are the two that are done, that have already happened in this particular round of budget reconciliation. We're currently at the end of that second square. So last week, the House Budget, or the House Energy and Commerce and House Ways and Means committees took votes on the American Health Care Act. And so then the next step is for it to go to the Budget Committee and then the full House and then to the Senate. There is thought that this is going to move really quickly. It's already moved very quickly. A vote in the House could happen as early as next Wednesday. Senate leadership has said that they won't bring a vote to the floor of the House or the floor of the Senate until they know they have all of the votes they need to get it passed. But the thought, I think in those that are proposing this bill, the dream is to have it done by April. So this is a really quick path to go through. So now that we know the procedure for this, what's in this bill and what's not in this bill, what does this bill do? So as I mentioned, with budget reconciliation, there are things you can't take out of this bill or out of the Affordable Care Act. There are things you can't do that in order to change them, they'd have to be done through later legislation or through regulatory changes. So the American Health Care Act, or the AHCA, would keep in protections for pre-existing conditions. It would keep young adults able to be on their parents' plans till they're 26. There's no annual or lifetime limits on coverage. These are all things that are part of the ACA now. And then under the ACA, plans in the marketplace or plans that count as minimum essential coverage have to have these 10 essential health benefits. This is basically the menu of benefits that insurance companies have to offer as part of their plans. These all are things that stay in. What's out then? The individual mandate or the requirement that everyone has insurance or faces a tax penalty is removed. It is replaced with something called a continuous coverage requirement. Now, if you don't have insurance, you pay an annual tax penalty. I believe it's around 2.5% of a person's annual income. This continuous coverage, and that's for every year that you don't have coverage. The continuous coverage requirement says you don't face a penalty unless you've been uninsured for 63 or more days. Then when you go back to buy insurance to get insured again, you have to pay a 30% premium surcharge on top of your normal premium for a year, and then you're sort of done paying the fine. So said in a different way, current system, 2.5% tax penalty annually for every year you're uninsured. New proposal, you don't have to have insurance. There's no tax penalty, but if you don't and you go to enroll again, you have a 30% upcharge on what your premium cost would be for a year after you enroll. There's some debate about whether this will actually drive people to buy insurance, whether it's like a high enough penalty, or whether people will just wait until they get sick to enroll because 30%, they're willing to kind of roll the dice on that 30% more so than they would on an annual tax penalty. So we will see. The employer mandate, so the requirement that large employers, so 50 or more employers or employees, the requirement that they purchase insurance for their employees is no longer in there. The actuarial value requirements or metal levels, this is like the fancy term for how much insurance companies have to pay out in benefits versus what an individual has to pay out. So right now, if you go purchase insurance on the marketplace, you could buy a platinum plan, a silver plan, a bronze plan. Each of those different plans has a different percentage of what the insurer pays out versus what the individual pays out. So if I have a plan that's a 60% actuarial value, that means my insurance company is paying out 60%, I'm paying out 40%. The AHCA, the American Health Care Act, would get rid of those requirements. So insurers could essentially set different, amounts that they want to pay out in coverage. There's some concern that will lead to higher deductibles, but that, is a prediction at this point. The cost sharing reductions that are available under the Affordable Care Act are removed. So those are the payments or the subsidies that folks can get to help make out-of-pocket payments like deductibles, copays, or coinsurance less expensive. And finally, the American Health Care Act gets rid of all but one of the Affordable Care Act's taxes. So it cuts all of the taxes that pay for the ACA. It's about a $600 billion tax cut. Most of the tax cut benefit, most of the folks that benefit from this tax cut are sort of the upper 1% of 1% of income, like very wealthy folks and some insurance companies and corporations. The reason why this getting rid of all the taxes is notable, there are questions about how the bill would be paid for. If you get rid of all the ways that the ACA was paid for. I can tell you in a second when we go to the next slide how I think it's being paid for, but that is something to kind of keep in mind. So what's in it but different? So under the ACA, you can get tax credits based on your income. So lower income folks get higher tax credits, higher income folks get lower tax credits to help purchase insurance to make it affordable. The tax credits are tied to where you live. So a person in Nebraska gets a different tax credit than a person in New York. And it's also tied to the cost of the premium. So if I live in an area where the premiums are really high, the tax credit I get is going to be based on a percentage of that premium. So as premiums go up, tax credits also go up so that consumers don't feel the pinch as much. Under the American Health Care Act, the tax credits are flat and age-based. They're not tied to income. So when I say that they're flat and age-based, I mean that they are $2,000 for someone under 30, $3,000 for someone under 40, up to $4,000 for someone under 60. This is regardless of the person's income. So say a 25-year-old making $60,000 is going to get $2,000 a year. A 25-year-old making $20,000 is going to get that same $2,000 a year. It's not tied to geography, so that 25-year-old, if they live in Nebraska, is going to get the same tax credits as a 25-year-old in New York, and it's not tied to the premium cost. So if your premium goes way up, you still get $2,000. If your premium goes down, that $2,000 is going to go further. So very dramatic shift in how the tax credits work. The American Health Care Act also maintains Medicaid expansion as an option with that enhanced 90-10 federal match through the year 2020. It changes how the federal financing works after 2020. So people who live in expansion states who drop off of Medicaid, and if you know anything about Medicaid, people don't often stay on it permanently. They often, due to changes in income or personal situations, go on and off. And if you are an expansion adult, you drop off and come back on, you no longer get that 90-10 match. You just get the regular 50-50 match that states get. So this is really being done, I think, to kind of force states' hands to eliminate this program moving forward. The last big change based on what's in the ACA versus the AHCA is age rating. So right now, older adults can only be charged 3 times as much as younger adults. The thought behind that is to really make the policy choice of we're going to help older folks afford insurance, because before the ACA, they were really feeling the pressure in the marketplace because of rising health costs for older consumers and rising insurance costs. So let's have it so that younger people are paying higher premiums a little bit, but that older people aren't feeling the cost as much. The HCA would change that and allow for older people to be charged 5 times as much as a younger person. There is thought that this would allow premiums to go down for younger people so that more younger people would come into the market, making the pool younger and healthier, which could overall drive down costs. There's also thought that for all the young people you might get into the market, a lot of old people or older people are going to drop out because insurance will become increasingly expensive for older people. As you can see, the age rating changes to 5 times as much for an older person versus a younger person, but the tax credits don't increase that much. So an older person could be charged 5 times as much, but the maximum tax credit that they can get is only twice as much as a younger person. So it's only 3 times as much as a younger person. So there's quite a bit of difference. The other big change that's notable is the change to Medicaid financing that's in this bill. Under the ACA, Medicaid was maintained as the traditional program that started in 1965, where states pay a certain percentage based on the economic situation in their state, and the federal government pays a match for that percentage. So usually it's around 50% of state dollars and then 50% at the federal level. Lower income states get higher level of match. So some states might get 60 or 70% federal funding and then only pay in 30%. It's somewhat open-ended in that whoever enrolls can get this 50-50 match. So if you have a change in the economy, or if you have a change that would result in more people enrolling in Medicaid, each of those people would get that 50-50 match. The American Health Care Act would change that to a set capped funding per enrollee. So instead of sort of this open-ended 50-50 match, you would get a certain amount per Medicaid eligible child, a certain amount for a Medicaid enrolled senior, a certain amount for a person with disability. Once that amount has been exhausted, so once the state goes through whatever that amount is, it's on the state to figure out how to pay for any additional costs that that person might incur. The reason why this is troubling from a Medicaid perspective is that the caps are, well, it's really difficult to predict based on putting someone in a category that how much their health costs would be. So you could have a child with basically no health costs, and then you could have a child who has a lot of health needs. The same it can be said for seniors, for people with disabilities. So it's really hard to put a flat number on a person. At the same time, there's a lot of questions as to whether the caps that are being set would be high enough to allow for the Medicaid program in states to continue at the eligibility and service levels that they are currently set at. So the cap is set at 2016 rate. So it looks at the enrollment and how much Medicaid spending was occurring in that state in 2016, and then puts an inflationary factor on it. So the problem with that is that this wouldn't go into effect until 2020. So we're using 2016 past numbers to set a rate going forward from 2020, and then putting an inflationary factor on it that doesn't actually track how much healthcare costs will increase. So we're sort of starting in a hole, and then the hole is going to only get deeper over time. It would be predicted that this sort of system would lead to states cutting eligibility, cutting services, and creating things like waiting lists, or really shifting, having to figure out where to get money to pay for some of the services we're currently providing because of this cost shift. It's estimated that there's about $880 billion being taken out of Medicaid. So that's a huge cut to the program. And I think that's where some of the savings that would allow for this program, or for the HCA to be paid for, come from, since we're getting rid of the $600 billion in tax revenue. So what is the impact of this bill? We can talk about the components, but I think it's important to just talk about what the bottom line is. The Congressional Budget Office did a score of the bill, which is their independent, nonpartisan fiscal analysis of the bill. And they predicted that 14 million more people would be uninsured in 2018. And then in 2026, 24 million people would be uninsured. These are national numbers, and they reflect Medicaid and ACA enrollment. To put this in perspective, right now we have 9 out of 10 adults in the US are covered with insurance. That's the lowest uninsured rate we've ever had since that number started being tracked. The Congressional Budget Office predicts that in 2026, with 24 million more people being insured, we'd have a total of 52 million people with no insurance. So essentially it would take the coverage gains that were made under the ACA and get rid of them. As I mentioned, there's also that $880 billion cut to Medicaid that's in this. When we look at the tax credit schemes, and some of the way that works, and the age rating and some of the different factors in that, it's probably going to be the case that younger, healthy urban consumers may do better off under this plan, but older, sicker, rural consumers will not do as well under this plan. As we talked about, older folks will see that the tax credits they get may not go as far, and they can also be charged 5 times as much. For rural consumers, the cost of healthcare can be higher in rural areas where there's not as much competition, or where you think about if you're living in a really rural area and you have to get transported to a different community to get your care. All of those things are factors in how much healthcare costs. This plan would not really benefit those folks. Essentially, it flips who gets assistance. When I say this, I mean the ACA really looked at how do we get low-income people the help they need to be able to buy insurance. How do we focus on making sure older people aren't disproportionately negatively impacted by premiums, and trying to kind of create a equitable system across rural and urban areas. The new proposed bill would allow younger, healthier people to get more assistance in purchasing subsidies, up to a higher income level. So folks up to $75,000 a year could get tax credits. So that means that some people who make too much income to get tax credits now would get tax credits under this bill, but others will see that are currently getting tax credits now will see that their tax credits don't really go as far. So an older person getting tax credits now, if their plan can go up 5 times in price, the tax credit they will get isn't going to go as far. So it's really sort of a policy shift in like who we're trying to get into the market versus who we have in the market now. So that's a lot of information that we went through really quickly. And there are a couple questions in the chat box, and we'd be happy to answer any more that folks come up with. And I'll also say my contact information, I believe, is on the last slide of the presentation, and you're welcome to email me or call me anytime with any questions, because I know there's tons of information on this that's coming out, but we can answer a couple of these questions. If this passes before the end of the year, what happens to consumers who are currently receiving tax credits through the marketplace? So I think there is a lot of uncertainty with insurers right now moving forward for 2018 coverage, but if consumers have purchased plans and are receiving tax credits now, that is already set under contract with the insurance company. So I don't know that there will be huge disruption to what folks are currently getting now. But I think things moving forward in 2018-19 would be where we see some changes. It's also worth noting that the insurance companies have to decide whether they want to participate in the marketplace by April. And so I think that this will be something, that sort of uncertainty will really be like weighing on insurers in terms of making that choice of whether they're in or out. I heard that the protections for pre-existing conditions in the new law would mean that you can't refuse someone, but you can charge more if they have a pre-existing condition. Is that accurate? Yes, but let me explain. So you can't refuse someone coverage because of their health status, so because of having a pre-existing condition. You can charge them more under that continuous coverage requirement. So you can't charge someone more just because they have a pre-existing condition, but if they have a gap in coverage that's more than 63 days, then you can charge them that 30% on top of the premium amount to under that continuous coverage requirement. So that continuous coverage requirement applies to everyone regardless of their health status. So it would impact people with pre-existing conditions and people without. So in that respect, yes, they can get charged more, but it's not as if the insurer is going through and saying, okay, this person has a pre-existing condition, charge them more, this person doesn't, charge them less. Feel free to chat. More questions in the box. There's one.
I have one. Do tax credits step down with income in the AHCA?
Tax credits are not based on income at all in the AHCA. So regardless of your income, you get the same tax credit. If you are under $75,000 a year in your income, or joint filing household income under $150,000 a year, you can get tax credits under the AHCA. That's the only way that income factors in. And that was really addressed because I think during earlier leaked plans of this, people were really concerned that like Warren Buffett's going to get the highest tax credit, even though he doesn't need a tax credit because he would be in the highest age bracket. So tax credits, the only income factor is that upper level $75,000 or $150,000 income limit. Everyone under that income limit who gets a tax credit, income is not taken into account ever after that. It's only based on age. So I believe it goes up by $1,000 for every like decade of age you are. So younger person gets $2,000, or so person in their under 30 gets $2,000, under 40 gets $3,000, under 50 gets $4,000, and then under 60 gets $5,000, and then 60 gets $6,000. 60 and up gets $6,000. So that's sort of how it works. But in that way, it would allow for higher income people to get tax credits that are higher than what they could get now. Because, if you were like up at the top of the current tax credit structure, you either might, like a 25-year-old who makes $60,000 a year and has a household of one is probably not going to get a tax credit under the current system because they're probably making too much. They could get that $2,000 tax credit under the new system.
Even if they have coverage through their work?
No, you would have to show that you're not covered through your work or through any other, like Medicaid or Medicare, just like under the current plan. But it would allow for some people to get more credits, and then some people will get less credits. And it really just breaks down into like who we're helping, as I mentioned. So like older people will maybe find that like their tax credits don't go as far in this, but a younger person, like a 22-year-old making $60,000 a year is going to be like getting a pretty sweet deal. Any other thoughts on that? Eric is nodding like
I'm learning
a
as
lot.
we go as well. No, I'm good.
Okay. All right. Well, feel free to chat any more things. I know I ran through a ton of information really quickly, so let it marinate and chat it in the box, or otherwise feel free to email or call. But the one other thing we wanted to mention is that while this is, so I guess to take a step back, the administration has really said that this is going to be a three-pronged approach to repealing and replacing the ACA, and that this is the first prong. So the first prong is to do this repeal bill through reconciliation. The second would be to do some regulatory changes and rulemaking changes. And the third would be to do even more legislation that you can't do through budget reconciliation. So I think on the campaign trail, we heard the president and others running for Congress talk a lot about how we need to be able to buy insurance across state lines. That is something you couldn't do through budget reconciliation, but you could do through subsequent legislation. So that would be like phase 3 of the big plan. So that's just to keep in mind that this isn't the end of the story. One other thing that's being proposed right now is being called the Insurance Market Stabilization Rule. It's a proposed regulation or regulatory changes for 2018. The timeline on that, it follows the normal kind of rulemaking process in the federal government, but they have to do a notice and comment, and they have to like look at the comments and then review everything, but the comments I think on this proposed rule were due the 7th of March, so it's still pretty new. This rule would try to address a number of complaints that insurers have about the current ACA marketplace, and really try to do that in order to get more of them into the market or to prevent insurers from leaving the market for the 2018 plan year. I think there are concerns from consumer groups and from folks enrolling people in coverage about the impacts of this rule, but what would be in it is requiring verification before someone could enroll in a special enrollment period. So there's a lot of talk among insurers that people sort of game the special enrollment period thing because we don't ask for that verification up front. So this would require someone to prove that they do qualify for it before being able to enroll. Under the current system, you can have like a 3-month grace period and non-payment of premiums before cancellation of a plan. There's some insurers say that people game that system by waiting and like paying their premiums through the 9th month of the year and then just don't pay for the last 3 months and then don't have any sort of penalty because the plan is done at that point. So this would allow an issuer to collect premiums for the prior year or prior unpaid coverage before they enroll consumer in the next year's plan with the same issuer. So if someone had, for example, a Medica plan and paid for 9 months of the year, didn't pay the last 3, and then tried to go and enroll in a Medica plan again, Medica could say, hey, we're not going to let you enroll until you pay for months 10, 11, and 12 of last year's. So that's one change. There's some rules around what provider networks have to look like in plans. This would kind of free up some of that decision making to states. It changes the rules around, or it would change the timeline around the 2018 certification of plans. So plans have to go through that certification to be determined a qualified health plan, and then also do that certification process around like how much they're going to increase their rates, and it's somewhat of a public process. This would change that to speed up or to push back when that occurs, and to allow if any of these proposed pieces of legislation or if there are any changes that they could incorporate that into their decision making before they go through that certification process. The last thing is that it would shorten the 2018 open enrollment period from our current 90-day enrollment period to 6 weeks or 45 days. The reasoning behind that is that it would align it better with Medicare open enrollment, which is 45 days, and would also align it better with employer-based plans. Like when you start a job, you usually have 45 days to enroll in coverage. I think consumer groups are worried that like that's not enough time to get people enrolled. But those are, that, like I said, that's a proposed rule. It's very possible that not all of these things or any of these things will actually go into effect, but there's changes happening in legislation and administratively, so kind of have to keep our eyes on a number of different places right now. So resources. We put together at Appleseed this American Healthcare Act fact sheet that walks through the sort of what's in, what's out, what changes, and some of those bottom line numbers around coverage losses and cuts to Medicaid into a one-page fact sheet that's available on the Enroll Nebraska website at enrollnebraska.org/EEG. Other resources.
So this one is something we prepared for anybody who's dealing with consumers, which should be everybody in this webinar. Anybody who has clients who are low income and who might be affected or who are enrollment assisters themselves. So messages on the ACA today as of, I put tomorrow, sorry.
As of today and tomorrow.
It could change. But basically some short messages that we know, and we aren't using our psychic abilities because we don't have them. So these are what we can say today, along with some further reading from partners about dealing with some specific circumstances like the immigrant and refugee population, specifics around the AHCA, and one other. So basically, we're asking folks or telling folks that nothing has changed. The ACA is still the law of the land. And as this moves through, however fast or however slow, we'll keep you updated as it changes. And then the last bullet on our messages was that it is okay to continue enrolling in special enrollment periods for the 2017 healthcare.gov enrollment session. So this is a quick fact sheet about those special enrollment periods, what qualifying life events are out there. It is easily given to anybody. Print them up and hand them to folks who might be available. But if you are an enrollment assister, you can download it as a doc and add your contact information, just your phone number or whatever you need on the front or back. Easily editable for you. Also downloadable. All right, so Molly, I really want to thank Molly for being here. She has read the entire text of the HCA as well as about 1,000 commentaries on it by now, I'm sure. So she is a great resource for you and for us. I'm here still asking questions myself. So if you want to ask me anything, I can pass them along or give my best reference or referral as it comes up. So we have a couple more slides. Doesn't look like any more questions have come in, but I will go through a couple of these slides and we'll get back to these questions. Feel free to put those in the chat box on the bottom right, and we'll definitely get to those. So as I said earlier, and as you're writing questions, I'll mention these. We're going to host another webinar with the Medicaid managed care providers, the 3 of them in our state, as well as the enrollment broker that's been supporting the Medicaid managed care transition. This is still a very new program, and lots of folks out there attended our Medicaid managed care Heritage Health webinar way back when. We want to get the same group together to talk to these folks. We have time for Q&A and everything with them as well. Like I said, the date and time isn't set, but it will be in April. And Molly and I will also be around to do another current events webinar. It will go out over the email, and anybody who signed up for this will be on that email. I guess finally at enrollnebraska.org/EEG, there is a webinar, or there is a survey for anybody who's been a part of the webinar. So if you have been a part of this or others in the past, or know people who have, feel free to send it to them. We're looking for feedback to do these better.
One more question. So I did this presentation this morning and got the same question, and I'll give you the same answer. It says, honestly, not that you can see into the future, but do you think Republicans will end up working together to move this forward in the current state? I should really not be in the business of making predictions about this because I didn't think we would be in this position with the bill that we have before us. As you probably know, there's been tons of leaks under this new administration, and the healthcare stuff has been no exception. There have been a number of different leaked drafts of an ACA replacement, and this bill looks a lot more, it keeps a lot more of the ACA than what I thought people who wanted to repeal the ACA would want to keep in. So that is surprising to me. I think what I'm reading right now is that they have, depending on who gets asked, they think they have the votes to get it through the House. The Senate seems to be where the real sticking point is. I will say that there are a number of different ideological viewpoints that are sort of conflicting with each other, and I don't know that this legislation really resolves those. So you have a group of people who don't want any tax credits in this at all. You have another group of people who say the tax credits are too low. You have another group of people who say, I don't want anything to do with Planned Parenthood in this bill. You have another group of people who say this bill should defund Planned Parenthood. You have some states that say Medicaid expansion should be eliminated, or some senators or reps that say Medicaid expansion should be eliminated totally. You have others that say the protections in this bill for Medicaid expansion don't go far enough. So they have a lot of work to do to get everyone rallied together. But I wouldn't be able to predict whether they can do that or not. It's a fast timeline, so got a lot of work to do in a short amount of time.
Yeah, and I'd add that we are keeping up with the news as best we can, but for you to catch up with it as quickly or quicker than we do, we subscribe to a great news service called Kaiser Health News. Gives a digest of the news of the day before, the morning you would get it. So look up Kaiser Health News. I will put it in the chat box. And you can learn a little bit more as it happens between when we do this webinar and our next one. So if there are no more questions, I want to thank everybody again for joining us. This will be archived at enrollnebraska.org/EEG for anyone to view or replay. So feel free to share that with others. Thanks everybody for being here, and we will talk to you again soon.
Bye.
Bye.